As I'm sure you all saw from the description of the event when you signed up and so on, what we're going to do is tap the brains and the smarts and the experience of Dr. Rossi and Dr. Brookman, who are here with me today, who teach the clinical reasoning workshop, first-year clinical reasoning workshop at the University of Puerto Rico, who happen to be partners of Sketchy and DDX. And yes, we're going to talk a little bit about DDX, which is something you can learn more about if you want to book a meeting with us when we're done, et cetera, et cetera. But what we really want to focus on is how University of Puerto Rico in their clinical reasoning class is indeed using these tools, among other techniques. I'm going to talk more about more than just DDX. We'll have a little live demo in the middle as well. I want to hand the microphone over to Dr. Rossi and to Dr. Brookman to introduce themselves to get started.
Hi, hello everyone. Thank you for joining us. I'm excited to share our journey here at the University of Puerto Rico Medical Sciences campus as we reimagine how and when we teach clinical reasoning to medical students. My name is Dr. Nicole Rossi. I'm internal medicine and geriatrics physician, and I am associate professor at our university.
Hi, I am Dr. Brookman. I am a neonatologist and I'm an assistant professor at the University of Puerto Rico School of Medicine. Thank you for being here.
We both currently direct the Introduction to Clinical Skills course for first-year medical students. And to give a bit of context, our institution follows a traditional curriculum model divided into preclinical and clinical phases, but with intentional longitudinal integration, and clinical skills serves as one of the key threads that spans all 4 years of training.
Yeah, and the kind of arc we're going to go through here is going to hear from both of you in turn about a few more details about exactly how this longitudinal clinical skills workshop is put together. Then some of the challenges that you have had, how you've overcome those challenges, how you have been working towards them using tools like DDX, but also other techniques and things you've learned in the process, how to work around those challenges. And then we'll talk about thoughts for the future. I am going to end the poll. So thank you very much for answering thank you very much for answering that brief little poll, everybody who's here. And I will say, please, please, please be active in the chat. There are a couple points, especially when we bring up our little demo, where I'm even just going to ask you all for some thoughts. But any questions or comments you have, please put them directly in the chat, or you can use the Q&A function in Zoom to send a question. Either way, I'm going to do my best to keep track of these questions. And if it makes sense to ask them in real time, I'll just be the MC more or less and send them over to Dr. Rossi and Dr. Brookman. But we also have time set aside at the end to answer those questions. So don't worry, we'll get to them. And if somehow we have way too many or we don't have time, there are ways to get in touch afterwards. But with that, Dr. Brookman, I am wondering if you can explain for us some of the details about the Clinical Skills Workshop.
Yes, thank you very much again for this opportunity. First of all, as we want to talk about what we had before, so you can keep up with us. What we had before, how we face the challenges that we got, and then Dr. Rossi is going to talk about what we're doing right now, okay? Basically, first of all, identify our gap. And as all of us that teach to medical students, we know the feedback of them is very important. And several years ago, we identified a critical gap in our curriculum through student feedback. In the famous graduation questionnaire that we have from them, they expressed that they did not feel adequately prepared in clinical reasoning for their clinical years, okay? This wasn't just anecdotal, but it was consistent theme across our cohorts, okay? At that time, formal exposure of clinical reasoning began in the second year of medical students in the second year of medicine through the Fundamental of Clinical Diagnosis course. While that course was well structured, it became clear that waiting until the second year was too late for students, and students were already encountering clinical scenarios every single day from the beginning of medical school. Okay, so we asked ourselves, what would it look like to introduce clinical reasoning earlier, a lot earlier, and could we scaffold these skills from the very beginning of medical school? So that's what we did. In response, we made a strategic decision to embed clinical reasoning directly into the first year, specifically in the Introduction to Clinical Skills course provided in 2021. This chief aimed to focus on three things. First, strengthens our students' diagnostic thinking from the outset. Second, normalize uncertainty and interactive thinking. And third, prepare our students for clinical encounters with structured reasoning framework. We didn't want clinical reasoning to feel like something, like a separate skill, like something that they cannot reach, something that is difficult to get to. But instead, it needed to be woven into how students approach every patient interaction, okay? So first year students, we created this lecture, and first year students now attend a dedicated lecture on clinical reasoning designed with 4 key objectives. Improve metacognition by making the process of learning and thinking explicit. Define core terminology such as illness scripts, summary statements, semantic qualifiers that we know that at the beginning are very difficult to identify and to work with. Recognize the clinical reasoning framework and common pitfalls that we encounter every single day while we're working with patients, and apply a systematic approach to real or simulated cases. We emphasize that clinical reasoning is not just for seasoned clinicians. It is a skill that can and should be practiced from day one. We also, in that lecture, introduced tools like the Vindicated acronym to help students think mechanically and avoid premature closure and providing wrong differential diagnosis. After the lecture, following this lecture, students participated in a small group activity using a single clinical case. And I want to emphasize in that one single clinical case. In 2021, we had 106 students class divided into groups of 8 to 10 students across 3 days, each facilitated by a faculty member. Facilitators were encouraged to promote active participation. Students generated differential diagnosis as the case unfolded step by step, refining their thinking with each new piece of data. They were guided to justify their history taking and review system questions, articulate how each data point influenced their differential, and practice clinical reasoning in real time. This was a powerful exercise, but at the end, when we want to scale it to larger, it was very difficult to do. Next slide.
Yeah, absolutely. Let's focus on some of those, huh? Yeah.
Thank you. When we expanded the activity to include 3 cases, and I want to remind you about one case was 10 to 12 groups or smaller groups for an effective activity. So now we have 3 cases, and we run into logistical challenges. Each session required 10 to 12 facilitators to support small groups, meaning 30 to 36 facilitators for the whole 3 cases. Faculty availability was limited, and scheduling across multiple sessions proved difficult. And finally, variability in facilitation styles affected the consistency of student experience. Not all of them were receiving the same experience that they deserve. Next slide, sorry. Then we trial, in response to that, we trial a larger group format to reduce faculty burden. But Then we found that the engagement and discussion quality suffered. Students were less likely to speak up. Maybe they were intimidated by a larger group around them. And the richness of the reasoning process was diluted in the big scope. We needed a solution that preserved the integrity of the small group reasoning while being scalable and sustainable throughout the years, okay? And then that's when DDX happened.
Yeah, and Dr. Rossi, I mean, really both of you were, but Dr. Rossi, I know you were right at the forefront of this when we tried this out in fall 2024 in order to help scale. So what, yeah, help explain what did you do with the tool? How did we try it out? And, you know, why did it help? You know, what were you going for?
Well, at that moment, we were experiencing all the challenges that Dr. Brookman was telling you all about. Then Dr. Medina, our curriculum director, approached me and talked to me about the Sketchy DDX tool. And we were really excited. So we got in touch with the Sketchy, and in the fall of 2024, we launched a pilot using the platform. It's centered on an abdominal pain case, which was one of the chief complaints that we used in one of our previous cases when we did it in the small groups. And under faculty supervision, groups of around 33 students that were subdivided into teams of 6 to 8 students per team. And we allowed them to work collaboratively throughout the case. So they were doing the case using the platform, but under guidance and faculty supervision. The students were given a survey before doing the case, and they did a post survey after. The platform allowed the students to engage deeply within the diagnosis process, learn to navigate the DX tools, and practice reasoning in a structured and interactive format. They were really, really excited that day when we were using the tool for the first time. The pilot yielded encouraging results. We have a very positive feedback from our students, and Adam will tell you about the measurable increase in the clinical skills confidence that they stated in the survey. So students appreciated the autonomy and the opportunity to work through the cases at their own pace while still receiving faculty guidance. So building on this success, we formally integrated Sketchy DDX into the clinical skills workshop in January 2025. At that moment, 8 cases were assigned, not at the same time, asynchronously for individual completion. Student engagement remained strong and feedback was overwhelmingly positive. Many students reported that they felt more confident approaching real patients and more equipped to generate meaningful differentials. At that moment, I was even receiving emails from students asking for more sketchy cases. Okay.
Go ahead, sorry.
For the 2025-2026 academic year, I think it's the next slide. Yes, please.
I think we can we're talking about moving into the fall.
Yeah, for the 2025-2026 academic year, we are launching the first full year of DDX integration with 12 cases aligned longitudinally to system-based blocks. And this alignment reinforces clinical relevance and supports diagnostic reasoning across the curriculum.
Yeah. So I think we can jump over. Is now a good time, Dr. Rossi, to show the case itself? I think we actually have the one that we that we tried out. So let me bring this up here. This is the case that we tried out for that fall 2024 pilot. We wanted something that was appropriate for first year medical students. And what we have is we have a case library of a lot of different presentations and across different systems and different settings. But we thought this one was appropriate. You noticed we haven't talked about the underlying disease because we're going to play a little game together. And I would like to ask everyone here in the chat, and I do see there are a couple questions in the chat. I registered those questions. I'll make sure that we get to them and ask them. But I do want to ask everyone to, fill in the chat and put in here, because what we're going to do is we're going to go through this case, same case that the small groups of students at the University of Puerto Rico did, at least the first few steps of it. What we do with DDX is we essentially take what you would have in a paper case, each step of that, the history, the orders, the differentials, and so on, and we make it interactive, and that is what allows it to scale and be kind of self-proctored without the kind of logistical challenges that Dr. Brookman was talking about. And this particular case, I'm going to start it, and I'm looking at it as a student right now. And he has presented. He's clearly not feeling too well, but we're trying to get a history of him, and also not just his symptoms, but also medical, surgical, family, and social history. And here he is, and he has just said, "Hey, stomach pain is bad. It hurts a lot." Go ahead and put in the chat. What kind of questions should we ask him? What should we say here? What are we trying to find?
I want to add something. Please feel free to enjoy the experience, and just although you need to reach 8 key findings that you see at the top right corner with the stars, focus on doing what you do daily. What is your history process, history-taking process? What questions should you ask? What questions do you do after your shift complaint and all that stuff? So enjoy. Let's tell us, what questions would you ask to this patient that comes in and is an 18-year-old male with abdominal pain?
Adam, I saw an interesting comment that says they want to ask, "Tell me more." And it's interesting. I don't know if you want to type that to see what the AI will respond.
Yeah, I did. Yep.
Okay.
And we got one. He didn't tell us everything, but he told us a little bit more. And we'll see what the rest of these are. I'm just gonna pick a few here. Where specifically does it hurt? He actually already said, "I'm not sure where exactly it hurts the most." But we'll say, "Can you describe the pain a little more?" We have a couple questions around that. Wonder if that's going to hit. Oh, it just feels like everywhere. Tough to pinpoint exactly. Well, we'll say, do you have any history, family history? Do you have any personal history of pain like this? I think maybe we have some personal history of abdominal pain. It wasn't as bad in the past. How about family history? Your parents or other relatives? So his dad has a history of kidney stones. So now we've found 2 of the key findings. And the way the platform works and the way these cases are configured is that when the dialogue that you have with the patient, or as we'll see, it's not always with the patient, sometimes it's with other characters, hits on key details of the case that will help us later on, we get a star, we get a point, essentially. Now, one question we get a lot is, do you always have to see the points scored in real time? Can you hide it sometimes? Actually, you can. That's actually one of the options that you can work with us to do. But especially in more of a formative assessment, kind of interactive, I think that the 2 of you saw firsthand when you were running this, the students get very, very engaged in trying to get all of the findings of any given step,
Yes.
Right? Yeah.
Yes, they do. They don't want to go on to the next one until they get all
the key findings. And I have to say that sometimes they get so anxious that and us too, we skip steps. And for example, family history is perfect and it's a key finding. But before that, I would have asked nausea, vomiting, maybe loss of appetite, which are associated symptoms to abdominal pain. And maybe when did it start exactly? if it happened before that you already asked that. As we know, the 7 attributes to the chief complaint, alleviating and aggravating factors. What else can we ask?
Trauma.
Trauma,
Yeah.
sick contacts.
Any nausea? Michael in the chat had also mentioned the same thing here. Nausea, vomiting,
When we finish,
diarrhea.
when we finish the shift complaint, then we can go to past medical history, which is any hospitalizations, any accidents, any medications or allergies, surgeries. And we have 40 questions, and we already have 5 of our key findings, and we still have 32 more questions to go. So we have plenty of space to ask those questions, and they can follow the whole history taking. After that, we can have the family history that we already have, that he has nephrolithiasis in their family. What else? I think that's, we have an 18-year-old boy, social history, drugs, alcohol use. Where does he live? Is he studying?
There's an interesting, I'm sorry, Adam,
No, go ahead.
tool right there that it says hint. I don't know if you want to click that so that they see what it comes up. Because if the students get, stuck, they don't know what else to ask. You can always ask for a hint.
And what happens if we ask what it asks for? Any changes in vowel habits?
Patterns. Vowel habits.
Or patterns. There we go. History of chronic constipation. There we go. And so yeah, we rounded off with the last one too, but go ahead, Dr. Brookman.
So we have an 18-year-old male with history of constipation in the past that presents now with history of abdominal pain, that is a generalized abdominal pain associated to diarrhea last week, I think, something like that. And he also says that he had a alcohol binge recently.
That is what he said. I do drink, especially with all the frat parties going on. And so I use the hints to kind of get us over the hump and find the rest of these here. And we'll move on to the next step here, because I think this will show how we handle interactive physical exam cases in DDX. One thing I'll mention before we move on is you might have noticed this little icon here that says talk. This can be done with two-way voice communication as well, just because of the way these webinars tend to work. Sometimes the audio, like if I try to talk here, it picks up other things, and it doesn't work perfectly. But I'll be mentioning this later too. You can drop us a line and meet with us for a bit and get a trial. And the two-way voice, we actually work with one of the leading AI labs. 11 Labs is actually the folks we work with. They did a recent article on us and how we use this and how reliable it is for the two-way voice interaction. But we're going to move to the next step. Oh, go ahead.
And I want to mention that although we already have the key findings, you can ask all kinds of questions and the interaction will be there. They will answer your questions, bloody stools, bloody vomiting, or et cetera, and the patient will answer all those questions appropriately.
Yeah, what's really interesting is because of the way that we have set this up, and this is AI assisted. There were a couple questions about what models we use, and the answer is we're actually always trying out the new models and the updates and things like that. So it does change from time to time. But we have AI assistants here, but we have given the AI that is simulating the patient a number of guardrails about who they are, what their background is, what this activity is. But it will also fill in the gaps, even with things that we haven't said. If you ask a DDX patient what they had for breakfast, they'll actually tell you something. They'll say, "Can we talk about my abdominal pain, please?" After they say, "I had some eggs this morning" or something. but they will answer it. There was one of these we programmed who really liked Chicago style pizza. We made sure that he talked about that a lot just to see if we could get that. But that one was just for fun. But let's move on to the physical exam. So we have a history on Jake, and Dr. Nair, who's one of our attending MD characters that we have in DDX, is going to perform a physical exam, and we are being given directions as a user, as a student, to give some specific asks. So if we go over to the next page and we just say abdominal exam, so we do have his vitals, but we don't have any physical exam beyond that. And if we just say abdominal exam, we're gonna get we're gonna get slapped and say, hey, come on, what specifically? You can't just say abdominal exam. Clearly, that's what's important. But what should we do? So again, I would ask it. This has been really active in the chat. It's been awesome. What should we say? Where would we want? What would we want to do specifically? And in this case, I will mention, we're going to talk through a little bit in a minute too. But this is, we're not interacting with the patient anymore. We're interacting with the attending. And the setup here is that these first-year medical students using the DDX product are imagining themselves in their clinical year, more or less. Yes, and so therefore working with attendings and professors there. So I see a test for rebound tenderness. No rebound tenderness. And then what else?
But we have a patient with abdominal pain. Before we touch him, we would observe, look at the skin. Is he distended? Does he have bruises, scars?
Yeah.
Any bruises?
Inspection first from Ingrid Mendez.
First, of course.
Perfect. Let's see what's happening there.
You do notice a light colored bruise and arrhythmia on his right flank. There we go. We got one key finding, bruising on the right flank.
Okay,
auscultation.
Maybe auscultation after.
I wonder if it's going to ask us where, but it might ask us for more specifics, but we'll go for that for now. Oh, here we go. We got it. Diminished boundal sounds in all quadrants.
Maybe palpation, all quadrants.
Percussion. Ingrid Mendez wants to percuss the patient.
It has lower quadrant, right lower quadrant tenderness.
Yeah. So we got another key finding.
Key finding, yes.
There we go.
And when we hear right lower quadrant tenderness, then we have to think about the other special tests that we do in right lower quadrant tenderness. Please tell me if you remember one of those.
Robson and Soa sign is popping up in the chat.
Perfect.
All right. Let's see here.
But it will not let you.
Oh,
it will ask you how to do it.
Oh.
Yeah. Got interesting.
So the student not only need to know the name of the technique, but how to perform the technique. The psoas may be elevating the leg against pressure or against my hand, for example.
Throw that in there. Oh, it took these in the order.
Yes.
So negative psoas, positive Rosving. And yeah, a lot of folks here, both the two of you and multiple folks in the chat, kind of hit on this at the same time, which is that we have directed the platform to ask why, to ask for details, and that's some of the flexibility here. Is that when we program these cases, we program them to the learning objectives of the case. If the learning objective of the case, if all you need from students at this stage of learning or whatever is just to say Rosving, then we can give them credit just for saying it. But if what we want to know is how is it performed, then we can give them credit for that. And in that way, it works kind of similarly to a lot of other open-ended assessments you might do in class for clinical reasoning, where you would align your assessments and your rubrics to whatever your objectives are. And one thing we've done, I'll just show this very quickly. We'll go back to the case in a moment. But that reminds me that we have cases at different levels of learning as well, and different features that are being asked for, different times of engagement. And so early advanced learner is roughly what we would say are preclinical and preclinical phases, though it's not an exact matchup, and different professors like to use different ones. That's why we use early and advanced as the terminology. And we've actually started to make some residency cases as well, along with different settings. And this, what you're seeing on the screen right now, is like the faculty view, because it's important for faculty who use it to be able to see all the cases and then select which ones they want to assign. Students then only see the cases that are assigned, and they don't get to see the diagnoses. We don't spoil that for them. That's special to the faculty. But yeah, I want to move forward here to just another step that we have a good number of. And now there is the presentation step. This one only has one key finding. This is one that we do relatively often, where there will be a, can you summarize everything so far? And the one key finding is it a good summary of it so far? And Dr. Brookman, I know you've been kind of summarizing as we go, the 18-year-old male, et cetera, et cetera. What would you type in here? Or maybe what should we type in here? We maybe just get it wrong.
Are we going to ask the audience or Dr. Brookman? I think Dr. Brookman has problems with her audio. She just...
Oh, maybe we can't hear it that much? That's a shame. Maybe we can't hear you, Dr. Brookman. We weren't having issues before.
I don't know. Anyone from the audience want to do a summary?
In the meantime, it is a little bit of a longer answer, so go ahead, type it in there if you have an answer for presentation.
But I think we have an 18-year-old male with a right lower quadrant abdominal pain, with a positive Robson and psoas. There's a history of trauma and chronic constipation. Okay.
Oh, I spelled male wrong, which is a little embarrassing, but we're okay. It's pretty sensitive, or rather pretty insensitive, I suppose. It is accommodating of things like natural typos, because it is flexible of things like that. Though I will note there have been some, I don't remember if it was you, Dr. Rossi, if it was another school we were working with, who they actually didn't want students to get credit for using some of the acronyms, because one of their objectives was that they type out, the full thing. You can't just say STEMI, gotta say the whole thing.
Yeah.
And we actually customized a case to work that way. But yeah, we've got this. It was a good representation, and she's sort of repeating it back to us as well. You can even see up top here what the other steps of this are, and we won't go through this case in total, but this is the case that your students went through. We would move on to a differential diagnosis step, orders, management, and then some questions. Typically, we don't necessarily do interactive steps about management and course of care all the time, because sometimes those are simpler and we like to do it by multiple choice. And we get into some even board style questions where we might introduce new scenarios and things like that. And that's how this case moves forward. Oh, Dr. Brookman, seems like we're working again.
Yes, sorry. And I want to mention that you have plenty of cases right now. When we started, there was no so many, but now there have plenty of cases. So abdominal pain, for example, I found several cases, and you can right now we're using it directed towards the system that we're working throughout the year. So we are assigning cases. We are assigning cases according to the system that we're working or teaching the students during the year. And that helps a lot so they can focus on what they're doing.
Yeah, that's definitely what we're getting into for this school year is aligning system by system. I think, yeah, you're with the cardio and respiratory and so on, because it's the first time that students get to start right away. In fact, there was a question that came up that seems appropriate. Martha had asked if before you do case assessments, do you offer introductory sections before starting interaction use of cases? For instance, introduction to medical history, medical terminology.
Yes.
Yes.
We do have a lecture about history taking in adult and history taking in the pediatric patient. Those two lectures are integrated with standardized patients that come and do a whole interview in front of the students. And we also have active learning through those lectures. And we also did the lecture with the whole group before starting the clinical reasoning to provide them with the knowledge and the basics of clinical reasoning. This is in a stepwise way. And after, then we have the small groups discussions with the clinical reasoning, the clinical reasoning.
Yes. They even have a role-playing sessions before we introduce this topic too, when they do active learning by playing the role of the patient and the doctor. And they also, I don't know, you mentioned the standardized patient practice session, right? With the taking a history for adult and a pediatrics patient. They also have another conference on how to conduct the interview and to establish rapport with the patients. So all those activities are done before introducing this platform. And they also, as we mentioned in the beginning of the webinar, they have the lecture on clinical reasoning per se.
And although they are having all these lectures before, they at the end or throughout the year, they will have not only practice of history taking and in the second semester physical exam with the standardized patient, but also with real patients in the hospital.
Yeah. And there was another question a little bit ago about how the clinical skills were assessed. I will mention how we did it for the purposes of the pilot, which we couldn't do terribly longitudinally because it was something that was kind of time limited, but we did do a pretty focused measure of confidence on certain steps. And using just one case, like this was the particular case, there's a history of physical, presentation, differentials, and orders. We asked we asked before and after, how confident, comfortable are you with each of these? And those scores went up by about 20% on a 1 to 10 scale just after the one case experience. And we also asked if students thought this was a useful tool and would like to use it more, and they said yes. And that kind of proven with your experiences of oh wow, now we get we get the level of focus that required 30 faculty members or at least 30 facilitation sessions, and we can do it just with the two of us, is I know what helped move forward. I'm curious though, what other measures of clinical reasoning do you use in your program in the bigger picture?
Yes. Remember that we are introduction to clinical skills. So in our course particularly, what we focus on measuring is the history taking and physical examination techniques. So the student have an OSCE exam on December of history taking skills of an adult and a pediatrics case. And in May, they have OSCE of physical exam, a complete physical exam. I think we won't have the answer to the question yet, because in fundamentals of clinical diagnosis, which is the clinical skills course for the second year medical students, building on the success we had with the tool this year, they will start using it this year. So we're going to be building upon those skills. And I'll guess longitudinally, when we see the graduation questionnaires of this class that's moving up to the second year, we will see a difference. The fundamentals of clinical diagnosis, there is OSCEs that measure the clinical reasoning skills. But for our course, we measure the history and the physical exam taking skills, okay? This is more of a formative, the Sketchy platform, the clinical reasoning activities are formative in our course.
All right. I'm going to, so we already talked about what we did in this past spring. You mentioned, I think 8 clinical cases total, and now we already have plans for more. Yeah, we are at over 100 cases in the bank for DDX, and releasing more on a monthly basis at this stage, actually. And I know we've been in touch about, hey, here's the new batch. Do you like these? Would you like to? I know one thing we've done is a good number of customization, because there are a lot of cases that we wrote where we think we've kind of assumed the average use case would be a professor who didn't need to be assessing physical exams as much. So if the physical exam was pretty normal, we just say what the results of physical exam are. But I know you've asked us to make those steps interactive, and we do that for you. And so I know we've worked hand in hand. But even just looking for the future, Dr. Rossi, I don't know if you want to speak to just what you've been looking forward to, and how you've been thinking bigger, kind of even beyond this year.
Yeah, if you can put the first previous slide first, I want to point out something.
Yes.
That we integrated the Sketchy DDX on the total grade to further incentivize our students. So on the beginning of this academic year, less weight is being put on the written test, and 10% of the grade will be awarded to the formative and the clinical skills per se, activities per se. So beginning this academic year, 2% of the grade of the course formative grade will be awarded for completing the sketchy cases with a score of 70% or higher. So this encourages thoughtful participation and reinforces the value of deliberate diagnostic practice. And in the next slide, so plans for the future, we are expanding the case library and the cases that we are assigning our students. We started with the pilot, then we did 8 cases. Now we're going to integrate 12 cases during the first year. As we said, system integrated. So to be able to expose our students to broader spectrum of presentation and pathologies. And also, as I said, fundamentals of clinical diagnosis second year med students are starting to use the platform this year too. So we're going to be able to be building up on that experience and expanding on the cases. And we, Dr. Lopez is the course director from the Fundamental of Clinical Diagnosis, and ourselves are in constant communication in order to make the transition seamless and do not repeat cases, and organize the both courses together.
Yeah, and this also speaks to just some of the work that is going on behind the scenes. The DDX platform, while we're proud of where it's at, I think it's valuable and it's helpful. We do actually have an active development team, not just maintaining, but actually expanding it. Checking off just a few things we're working on. When you say patient charts, what we mean is actually a persistent UI element that kind of tracks the process in the patient chart. And that's something that's going to be shipping within the next few months. It's bad luck to give exact dates for these sorts of things because technology is complicated. but actually it's pretty far along, and we know it's something that will be valuable, along with reporting for professors and higher stakes features where you can lock the use of cases to you can only use it once and they can't see how many stars they got. So I'm going to just look at their results so you can use it as more of a summative and final assessment tool. There are a number of questions that have come through. That is any chance for some kind of adaptation to veterinary medicine? There's a question that came in about that. There's another question about modifying cases to specific contexts or maybe different settings. Short answer for that is yes, you can work with our team to have kind of variant versions of cases. One thing we've done, for instance, I think I saw it in the poll at the start, there are at least a few folks from nurse practitioner or PA programs here. And we have adapted versions of the cases where the preceptors you're speaking to are PA or NP preceptors as opposed to ND preceptors, but also changes like that, such as the setting or other details about the patient, if it's really important to your program. That's the sort of thing that we can accommodate as a part of a partnership. And these are all things that love to talk with you about. I think if you're here or you're even watching this recording, you've seen the basic functionality. And so we can talk all about your program specifically and see how things move forward, whether that means implementing it next semester or piloting or giving it a shot. We are very eager to let you try it out yourself, essentially. Get that two-way voice mode going, check out all of our cases, and so on. Are laboratory/imaging studies possible on the platform? Dr. Smith effect, it looks like you might have answered that for me. By the way, hello. I know we've had a couple of meetings. Yes, we actually do. We have several cases. I want to say most, it might actually be literally most cases where we bring up media of an EKG or an X-ray or some other kind of imaging, and we ask for interpretation and so on. But yeah, Dr. Wilhelm, we've actually spoken to a number of other veterinary medicine programs at conferences and places like that. So yeah, reach out is what I would say. And we can see if there's some way to make it work. Obviously, it's significantly different. We can't just change the name of the patient, for instance. But for some focused implementations, especially if you're willing to partner with us closely, something that we could discuss. And yeah, there are a few others here. There's a question about is the goal, this is a hot take question, get ready. Is the goal to completely replace the in-person teaching, or is this meant to remain as a supplement in the long term in your mind, Dr. Rossi, Dr. Brookman?
It's not meant to replace it, and it's not a supplement either. I think that both interactions are important. We will still have the first in-person small group activity of clinical reasoning, but certainly it's, as we said before, it's not scalable or at least doable at our institution to do 12 in-person cases. So I think both approaches complement each other. So I think we'll be using both.
Basically, they wanted more exposure to clinical reasoning, and having the limited factor of not only faculty members, but providing the consistency that they all need. It's difficult throughout the year with a lot of cases and a lot of small groups, and these give us the opportunity to provide that, but it's only a tool, it's an addition. So it's not a replacement of the process. And I want to remind that we still have the standardized patients and the real visit to the patients, that they will still have that experience throughout the years of first and second year.
What we have really, what we've heard from the two of you, but also from a lot of schools that we've worked with, is that there really aren't any plans to decrease the amount of in-person interaction, but that in-person interaction with OSCEs and standardized patients and so on, there's less pressure on it, on the logistics, for one. But there's also less pressure on it as this very, very narrow opportunity for interaction and case practice, because the fidelity level of simulations like DDX is raising. You can get in your reps, for certain things, for history taking and some of the more straightforward, and applying your systems and schemas of gathering examinations and so on, so that you can go into those with more confidence, and also so that those assessments, the in-person assessments, can focus more on what can only uniquely be done there. Because there are many unique things that can't be done at a computer terminal as well, and that's always going to be true. But it allows it to be more focused on those, such as interpersonal interactions and sort of physical manipulations and so on.
It's a way for them to be exposed without being exposed. And let's be real, this generation works well with virtual experiences, and providing them the opportunity to make the mistakes and give the wrong questions first, and then make it better. And also the DDX tool provides the opportunity for us to supervise how long were they in the case, what percentage did they get right or wrong. So this is not something that they can say, I'm just going through this for 5 minutes and let's go and let's do another thing. No, they have to go through the experience to get the whole points that we will provide for them if they do it well. And we can see if they are doing or not well in the case. And most of them, the feedback is that they love the experience. And myself, when I did my first abdominal case, I was in a Airbnb having fun, and I forgot about the pool, and I was engaged in my cell phone, having fun, getting all my stars. And it was a very fun experience. And I'm sure they do have a very enjoyable experience too.
There are also a couple of questions that came through the chat on comparing DDX to other tools. And I mean, the first thing I will say is that I am, for many reasons, not qualified to speak to the details of tools other than the ones that we have here at Sketchy. But what I will say is that, first of all, the priority on the engagement and the kind of compelling nature of the experience is something we have always cared about at Sketchy. If you're here and you're hearing my voice, you probably have students who use Sketchy, our Sketchy Medical, our Memory Palace, SketchyMicro, SketchyPharm, etc., that are just really compelling, really fun, and just fantastic memory aids. And even though DDX is a very different platform, it's case simulation rather than basic science and memorization focus. It's been the same founders, same team, same philosophy that have approached this. And so we've infused this platform with that just in every little way that we can, because we know that's what keeps butts in seats. It's what keeps us engaged. It's what lets us push past the level of stress and workload and so on that all of these students have, is keeping things engaged. Plus, I mean, it is DDX brought by Sketchy. Students have a trust for what we've done with Sketchy because they typically interact with it and have heard of it anyway. So that's a contrast. But another thing, just from a technical perspective, is most other approaches to AI-assisted patient simulation are either very heavy on the academic side or very heavy on the technical side. That is, they are very kind of academic and kind of medical fact-oriented, sometimes at the exclusion of sophistication on the technical side, or the other way around. Software engineers who aren't working closely with clinicians and experts in the same way, and really making sure that we simulate, for instance, every step of a case as opposed to just patient interaction. And this has been one of our priorities, and also feedback we've heard consistently is that we bring in the best of both of those worlds. that we have you know, the tech chops to keep up with that, but that also Sketchy has always been developed in tandem with MDs and clinicians and experts. I'm just thinking to I saw the number of subject matter experts who you know we have on contract this past month, you know, like working for us, and it scrolls for a really long time because we are working with specialists in kind of every specialty to work for all these things. So I know we are at kind of T-1 minute here. There are some questions about tracking. We do track activity and time on task. Short answer to that. And again, if you want to follow up with us either via email or with a meeting, we can show you the whole suite of reporting that we have. And I think that covers, at least thematically, a lot of these. Oh, can you review the students' responses? Yes. You can review what they scored, and you can also download the entire chat history, actually. We try to make it so you don't need to read the whole chat history of everything, but you always can, especially Dr. Rossi. I know we talked about this. If you're a little concerned, they might be copying off of each other. You can see if they have suspiciously similar chat histories, different students.
And you can see how they scored in each individual part of the case, the history, the physical exam, the assessment, the management diagnosis, because we focus on the history, physical, and the summary statement, because we're an introduction clinical skills course. And the insights page of the Sketchy platform, the reports, you can see their individual performance in those individual areas, not in the case as a whole. And that's very useful for us.
Yeah, there's also a question about whether you ask students to work on cases individually or if you use a particular time block. I think you've done both, right? You've assigned us homework and done small
we've
groups,
done
right?
both. The first case is always done under faculty supervision in small groups, more so that they can get the feel of the platform and know how to work it. But after that, they are assigned individually. And they have timed block in their schedules. It's not like do it on your own time. It has an assigned time during the day that their clinical skills course is supposed to be running, that they have to do the cases.
Right. And yeah, now we're at T plus 1 minute from the end here. So I will address one more question briefly. Is a question about measuring clinical skills outside of short-term confidence or long-term longitudinally. And actually, on a slide a moment ago, this in quotes test mode for higher stakes assessments is actually the direct answer to that. It's something we already have a feature where you can hide key findings so students don't know whether they found everything in real time. But there are a number of schools we're working with, Puerto Rico included, who are interested in turning DDX into a true assessment tool rather than just a practice tool. And if that sounds interesting to you, and sounds like to at least a couple of you asking in the chat, we'd love to work with you on it. We know that's the next horizon here. I think tools like this are tools like this are the future of clinical reasoning assessment. I don't think I'm being too radical in predicting that, because these tools are only becoming more sophisticated over time, and they let us focus, work more efficiently, and so on. But yeah, Dr. Rossi, Dr. Brookman, any final thoughts, comments before we sign off today?
Yeah, if I may add, we started working this when you just launch as a platform, as a product, and I say that I witnessed firsthand how the platform has been evolving from the insights on the reports page, the number of cases, the functionality of the tool. And I only imagine it will get better and better.
Well, thank you very much, Dr. Rossi. We want to keep working with you on it. That's awesome. Dr. Brookman, any final thoughts or farewells before we sign off?
Can you hear me?
Yeah, we can hear you.
Yes.
Okay, I cannot hear you again, but if you can hear me, I just want to say thank you for this opportunity. I'm so glad to be here. And also, this generation, this is what they need. This is what they want. They're asking for changes that made medicine more available for them. And they feel comfortable with virtual experiences. And as we say, this is not something to replace, but to merge and to work with. And as Dr. Rossi was saying, we are seeing firsthand how this DDX is evolving, and it's working pretty well. It's working good. So thank you again.
Yeah. Well, and thank you so much to the two of you for sharing your experience here, for joining. Thank you everybody who attended. This is one of the most active sessions that we have had. Thanks for helping to differential and diagnose this fellow. He has appendicitis, by the way. I think we can spoil it now. Probably a lot of us have already inferred that around here, but we did. I think we avoided spoiling it. We can tell a lot of people, a lot of attendees have been creative and have been asking questions about how to move beyond this and apply it to your schools and institutions. Give us a call, reach out by anything here, watch this space for future webinars as well. And everybody have a wonderful afternoon, a wonderful week. And again, thanks Dr. Rossi and Dr. Brookman for joining us today.